Great. Well, it's a great pleasure to be with you today. And as Larry said, it's nice to be on this side of the lectern this time. So my science task is to talk about safety with sodium reduction and potassium supplementation. I'll try to do that. So I want to start by considering three of the longer-term trials, because I think many of the trials, of course, are short-term, and they're interesting in terms of safety, but the longer-term ones are perhaps more interesting. So I'll talk briefly on trials of hypertension prevention, phase 1, trials of hypertension prevention, phase 2. Phase 1 looked at 7 different interventions to sort of see what was the winner for prevention. And then the 2 winners were sodium reduction and weight loss. So phase 2 was a more extended study of those 2. Those are both done, as you'll see, in relatively young, healthy people not on medications. And then the third one, trial of non-pharmacologic interventions in the elderly, done in an older population who had high blood pressure. They're all behavior intervention trials aimed at modest reductions in dietary sodium. The approximate follow-up is 18 months in TOPE 1, 36 months in TOPE 2, and 30 months in TONE. Basically, TOPE 1 was a 2-arm parallel design. TOPE 2 and TONE were, TOPE 2 was a pure factorial, and as I'll show you later on, TONE had a mix of a factorial design and a 2-arm parallel trial. What I'm going to show you in terms of the safety experience will be from the cells that are pure sodium reduction and usual care. They all do use 24-hour urine excretion. They all use 24-hour dietary recalls and food frequency questionnaires. So let's talk about TOPE 1 briefly, just so you have the understanding of the design. You can see the eligibility, relatively young, healthy, not on blood pressure meds. They are what was at that time called in the high normal blood pressure range, 80 to 89 average. Again, multiple observations of blood pressure, at least 2 pressures on at least 2 occasions, which is what every guideline has ever recommended as a reasonable approach to deal with random error. So for the sodium reduction component, there are about 900 participants, and you'll see they're more in usual care than in sodium because it acted as a control for several of the active interventions. Just very briefly, sodium reduction was achieved, and I'll just make the point that I don't know if I can point here with this. Oh, thank you. So I'll just go through quickly. You can see there's a slight drop-off in the difference. This is the net difference between active intervention and usual care, but overall, 18 months, percent change from baseline is about 30%. Better achieved in in whites than in blacks, and in this case in women than in men, although that will not show up in other studies. So what do we find in terms of safety experience? Well, this was a healthy group, so there was only 1 death, so that was fairly non-consequential. There was a slight difference in body weight early on, which was not significant by 18 months. When you looked at the nutritional variables for active versus control, that's 18 months compared to baseline, there were significant differences in total fat intake, greater reduction in the active intervention participants. You'll see that's replicated in the other trials. There was a slight reduction in iron. It was mostly in the men, but even there, they were still above the recommended dietary allowance. No significant differences in most of the other nutritional variables. General well-being scores were consistently better in the active intervention group. We saw that at 6, 12, and 18 months. In TOPE 2, again, a similar sort of group, relatively young, relatively healthy. However, this group was an overweight group, so it was looking at weight reduction as well as sodium intervention, a factorial design. A slightly larger number in the sodium intervention component of the trial. And again, there was a net difference in sodium throughout. It tailed off a little bit over time, but 36 months, percent change, net change from baseline, about 24%. Again, we saw a better effect in men compared to women, but we didn't see much of a difference between the two race ethnic groups. And perhaps this is because this group had a higher socioeconomic status than the Tope 1 group. Looking at the safety experience, there were 12 deaths, so it's, again, a relatively young group. There was no suggestion, obviously not powered for this outcome, but there was no suggestion of any major problem with deaths in the sodium reduction group. Was actually a little more in the weight loss group. Looking at the nutrition experience, there was, you can see 18 months and 36 months here, consistent reduction in total fat, in this case in saturated fats and calorie intake. Weight difference was not significant. There were some other things that popped up. You have to interpret them, a bit cautiously because there are a lot of variables here. This is not adjusted for multiple comparisons. And now moving to tone, this is a very different group, obviously, older, 60 to 80 years, although they're quote-unquote healthy community dwellers. They were taking blood pressure meds. They all got down to a single med with pretty well-controlled pressures. And there were about 1,000, slightly under 1,000 people in the trial, about 2/3 overweight, about 1/3 normal weight, and you can see it's a mix of a factorial design and a two-arm here, and we're again in the factorial only looking at the cells that are pure sodium versus usual care. Again, the experience here was there was a decent difference in urinary sodium throughout. It tailed off a little bit over time. Again, better, men did better than women, as you saw in Tope 2, but no significant difference by race. In terms of safety experience, any adverse event, there was no difference overall. It was not powered, obviously, to look at cardiovascular events, but there was no suggestion of a big uptick in cardiovascular events in the reduced sodium group. In fact, the overall number of individuals and events was lower in the active intervention group compared to control. There was a consistent finding, and it was there throughout the entire trial, that there were less headaches in the reduced sodium group compared to the usual care group. And it's interesting that that was seen also in the DASH sodium diet trial, and it was seen both within the DASH diet arm and the control arm that going from the lower to the higher, there was a significant difference in frequency of headaches. So it's probably real, I would guess. Looking at the nutritional data, I'll just look at this is an average of the 24-hour recall during follow-up compared to baseline. And again, that fairly consistent finding of a reduction in energy, total fat, saturated fat. There were some other things that popped up, nothing terribly dramatic. Now I want to move from there to areas of concern. So 3 areas have been raised regarding sodium, where concern has been voiced. The first one is adverse effect on biomarkers, and I'll address that. The second one deals with adverse events on all-cause mortality reported in heart failure trials. And the third one, I'm not going to spend much time on because I figured other speakers would be talking about it, and you have a lot of expertise in it anyway, the epidemiologic studies of J-shaped curves. So let's talk about the first one, the effect on biomarkers. And I'll show results from 3 meta-analyses. And the first one here is a meta-analysis done by Grudel et al. And this is one where a concern was raised, and many people have referenced this meta-analysis, and I'll show you the data from it. And just so you're aware, the eligibility here is it had to be a randomized controlled trial, irrespective of age, irrespective of duration of the intervention, 8 or 24-hour urine estimates for sodium, and unhealthy people were excluded. Didn't exactly specify what that meant. With that approach, they got a lot of trials, 167 studies, and I'll show you trials versus comparisons in a moment. And there are two other meta-analyses that I want to use as a contrast, and they both use pretty similar methods. This is the Alberta trial, the Alberta meta-analysis done for WHO, and then the trial by Dr. He, not Zhang He, but Feng He in the UK. And they use pretty similar approaches to eligibility. So it had to be a randomized control trial, had to be done in adults. It had to be an intervention of at least 4 weeks, primarily because of concern about behavioral intervention studies and the length of time we would need to show effect. It had to be 24-hour urine estimates of the effect on the intervention. And there had to be some evidence that the intervention was significant, 40 mils or more here, 40 to 120 here. And the only difference between the intervention arms could be sodium, no acute illness or other disease. With this sort of approach, less trials, 36, 49 comparisons here, 30 trials, 34 comparisons here. So let's look at what was reported. This is looking at blood hormone levels, and this is the Grudel experience, and this is He, and this is Alberto. I've shown here in yellow or orange the findings that were deemed to be significant. Looking at all trials in the Grudel analysis, and they're all crossover trials, they report an increase in renin activity, aldosterone, adrenaline, noradrenaline. They don't give you the units of measurement, so I don't know exactly how they assessed it, but it was significant. If you went to trials that were 2 weeks or more, getting to a little more stability, the significant increases were still there. They were less impressive at that point, but you can see for renin, for aldo, and for noradrenaline, they were still significantly different. If you looked at the He and the Alberta meta-analysis, again, significant effects here for renin, aldo, for noradrenaline. Alberta did not find a significant difference for adrenaline, noradrenaline. So I think one could say that activation of the renin-angiotensin system and probably the sympathetic system is real, not terribly surprising for effective interventions, and less dramatic when you look at trials that are of longer duration. Now, what does that mean? I don't know. It probably doesn't, in my opinion, probably doesn't mean very much, because we use a lot of therapies that have very diverse effects on renin activity. And I just showed an example here from ALHAT. We're comparing, in this instance, three first step agents, chlorthalidone, which we know stimulates the renin-angiotensin system and the sympathetic system, and lisinopril as an example of an ACE that would do the opposite, and there's really no difference in the major outcomes. So I think we're just looking at a physiological response. The more important question is what happens to lipids, and Grudel reported a significant increase in total cholesterol, and much has been made of this. Many people reference it as showing a concern. Didn't show significant difference for LDL or HDL cholesterol. When you went to the analysis that required at least 2 weeks of duration, none of these were significant. And for the two other meta-analysis, the absolute values were much smaller, and by no means were any of them significant. The best individual trial, I believe, to look at this question is the DASH sodium trial, and they've looked at it in quite a bit of detail, and I think it's a very elegant exploration of this question. So what you see here, whether it's total cholesterol, LDL cholesterol, or HDL cholesterol, There is a difference between the control diet and the DASH diet at every level of sodium intake, but there would seem to be absolutely no effect of sodium on those lipid levels for any of the three outcomes of interest. Moving to heart failure, this is a very challenging area, complicated area. It's not an area in which I'm actively involved, but we know a couple of things. First off, many patients with heart failure are salt overloaded, not all, but many. Judicious reduction in sodium, dietary sodium is commonly recommended. Judicious use of diuretics is commonly recommended. There's a nice review recently in the New England Journal of Medicine on this topic. However, adverse effects have been reported in some observational studies and randomized controlled trials. I think the results are extremely difficult to interpret because usually the people who are, particularly in the trials, included in the trials have fairly advanced heart failure. They're minimally stage 2 New York classification, mostly stage 3. So it's a complicated pathophysiology. They're on a lot of drugs, and it's including frequent use of very high-dose loop diuretics. Many of the studies are very poor quality. Many observers have made that point. And then there's a concern regarding validity, especially for the randomized controlled trials, which, to the best of my knowledge, essentially all come from the same group, the cardiology group in Palermo. Now, who knows, but the Cochrane collaboration withdrew one of those trials after a careful review and a lot of backwards and forwards, and they were uncomfortable with the responses they got when the university was contacted. However, subsequent meta-analyses have used randomized controlled trials from the same group, and those are the ones that are usually referenced. And you can see they do report a big increase in their relative risk of mortality. Again, these trials have been challenged. I don't know what to say except that, again, the BMJ went to a lot of trouble. Heart, which is a part of BMJ Publishing, published a meta-analysis by Nicol Antonio, and that was subsequently sent to the BMJ Ethics Committee, and again, there was a lot of backwards and forwards with the university. There were a couple of concerns. One concern was that most people found it incredible or unlikely that a single group could generate such a large sample size in the period that it was said to be generated. So that put off alarm bells. The second was that there were identical duplicate data in different papers, reporting different trials, so that seemed strange. And then when the university was contacted and asked for the raw data, it was said to have been destroyed and was unavailable. So I think it casts a question over many of these trials. So it's a difficult area. I don't think we know the answers. The observational studies have yielded a variety of relationships, and you can I'm sorry, this is the general, and I think Larry has addressed this before, so I won't go into detail. Just say when you get to the general observation studies, they're difficult to interpret for all the reasons that were mentioned earlier this morning. I like to think that Nancy Cook's analysis using the randomized comparisons is in one of the more informative approaches. And the observational analysis of the follow-up to TOP 1 and TOP 2, because healthy, non-medicated adults, so the possibility of reverse causality is extremely unlikely. A lot of opportunity to get reasonably high-quality 24-hour urines to get a good estimate of sodium intake, follow-up for a long period, and high level of ascertainment of the outcomes, especially, of course, for mortality and a blinded assessment of the outcomes. Nonetheless, we still remain with questions. So moving quickly to potassium, is potassium supplementation harmful? And again, we can say the obvious. We know from NHANES experience that most adults seem to be below the recommended adequate intake of 4,700. We know in healthy adults, we heard this morning, that excess oral potassium is readily excreted by the kidneys, and when you go through the literature, it's virtually impossible to find any reports of a serious consequence, including a serious hyperkalemia from acute ingestion of potassium from naturally occurring foods in healthy individuals. Generally speaking, potassium supplements are well tolerated. Of course, especially as you go back to older literature and the higher doses of potassium pills that were used in that time, GI side effects were noted, including small bowel irritation, lesions, including ulcers. This is not very commonly reported these days, and it's certainly not been reported with dietary potassium intake. I think the concern here has centered around the response to oral potassium in patients with decreased kidney function, taking medications that would interfere with renal excretion of potassium, such as, in particular, ACEs, possibly ARBs, potassium-sparing agents, not so much dietary supplements, because the typical amount of potassium ingested with dietary supplements is actually quite low. So one of the more useful, I won't say great, but more useful pieces of information is a meta-analysis done by Franco Capuccio and his colleagues. And I just want to take you through the inclusion-exclusion criteria. Essentially, they used same criteria as the Alberto et al., and in fact used the studies that were in that meta-analysis. So I won't go through this again, but it's the same as I mentioned before. In addition, they required a report of a serum or plasma potassium. So with that sort of approach, they ended up with 20 trials. And here's a forest plot of the effect of potassium supplementation in these trials on urinary potassium excretion. And it's pretty substantial. It varies, of course, but all of the trials showed a bump in urinary potassium, and you can see the average here and the confidence interval around it. Looking now at the effect of the supplementation on serum or plasma potassium, a small increase. Here's the overall pooled estimate. So it's there. It's significant. It's not a substantial increase in serum or plasma potassium. The trials that had the biggest bump were trials that selected patients with hypokalemia. So that's where you saw the big bump. And patients who did not have hypokalemia are pretty much clustered close to, not at, but close to the line of identity. There were only 2 trials in here, or let's say there were 2 trials in which ACEs were used. It's too small a number, but the authors did provide an estimate based on those 2 trials. You can see the average bump is slightly higher, but not dramatically higher than the overall experience. And I'll come back to ACEs in a moment. And this is looking at the effect on plasma creatinine, and it's no effect. So if you summarize this, how would we assess this? Well, you could say in the randomized control trials, you got a reasonably substantial increase in urinary potassium excretion, small increase in serum potassium or plasma potassium. Greatest effect was in the trials with hypokalemia, no significant change in serum creatinine. Now, you'd have to look at the characteristics of who's in this meta-analysis. So it had a lot of locations covered. Most of these trials were conducted in adults with hypertension, but most of them were not on medications at the time they were enrolled into the trials. There were very few trials in older adults where you might expect to see renal disease or other concern settings for potassium supplementation. No trials had been conducted in patients with chronic kidney disease. Most of them utilized a crossover design. 100% of these trials employed KCl supplements, and you can see the range of dosage here. But the typical trial has about 60 to 80 millimoles per day. So there were no oral in this meta-analysis, no food supplementation trials. So I think, as interesting as it is, one has to be very cautious about generalizing this safety experience because they're short-term studies. They're all looking at K supplements with pills, and it's in relatively healthy volunteers. So it's useful, but I think limited by the nature of who's in clinical trials. What about in the general clinical environment, which is where you might start to get concerned? Well, I think probably the best report that I'm aware of comes from Geisinger by Chang et al. It's a prevalence study of close to 200,000 outpatients seen over a 3-year period of follow-up. And a couple of things come out of it. None of them are a big surprise. So the first is, it depends on how you classify hyperkalemia. You're going to get a higher bump at 5 than you'll get at 5.5. No big surprise. It depends on how frequently you search for the presence of hyperkalemia. So in all of these, you'll see the prevalence is lower when you're only looking at a few labs, and it's higher when you're looking at a number of labs. Now, because there's reverse causality there, because who are you looking at a lot of labs in? It's the person who probably has hyperkalemia. It depends on underlying renal function. No big surprise, as you go from pretty healthy kidneys down to pretty unhealthy kidneys, there's a big bump. And it also depends on what you require for the diagnosis. Are you going to go on a single observation, or do you require repeated observations of high potassium? So again, if you're going to require more than 50% of the observations to be above, in this case is 5.5, you're going to get a very, very low prevalence. And if you would take a single, you can get a pretty high prevalence, etc. They looked at the association with medications that one might be concerned about. So they looked at ACE and ARBs, K-sparing diuretics, beta blockers. And the one where there was the biggest risk seemed to be ACE inhibitors. That is consistent with other reports from the literature. Less of a bump with ARBs, some bump with beta blockers as well. And K-sparing agents, although the frequency of K-sparing agents in this analysis was much lower than for ACEs or ARBs, and diuretics obviously being on the other side of the equation. What about in trials? Well, in trials in ALLHAT, we of course had an opportunity to look at an ACE. One of our treatment arms was lisinopril. The dosage was 10 to 40 milligrams per day. Here's the sort of people who were in ALLHAT. They're over 55, hypertension, at least one other cardiovascular disease, indicator of risk, not necessarily a traditional risk factor. And there's the sample size. This analysis that I'm showing here is based on 1 year, and about 3.6% of people got hyperkalemia, defined as a K of 5.5 confirmed, above 5.5 or above confirmed. On target, Dr. Yusuf is here. He certainly could tell us more about this. As one looks at on target, both an ACE and an ARB and the combination were available for inspection. And you can see they use ramipril as the ACE, telmisartan as the ARB. Here's the dose. Most individuals are on the higher dose of ramipril. A relatively high-risk group. Most of them had cardiovascular disease, a good proportion of diabetes. Good sample size. Follow-up in this case, 4.7 years, and the report is 3.3%. For a K 5.5 or above. I can't remember, but Salim could tell us if that is confirmed. I assume it is. Just don't remember. Telmisartan 3.4, the combination higher. And looking at ASK, it's a bit peculiar to me, and maybe I'm misinterpreting it. When I look at it, ACE here is ramipril, 2.5 to 10 milligrams per day. Sample is non-diabetic, hypertensive, presumed hypertensive end-stage renal disease, GFR 20 to 65, and you can see the mean sample size here is much smaller, follow-up about 4 years. As I do the calculation, I come out with a surprisingly smaller percentage than I would have expected of hyperkalemia. Where are these drugs used? How frequently are they used? Well, I think we all know that they're commonly used in clinical settings. So if one looks, I just pulled two databases here. This is the 2014 National Disease Therapeutic Index, quarterly audit of 4,800 office-based physicians. Many of you know this is a well-oiled operation that gets us this information. And here's the percent of patients receiving medications from specific groups. Not a big surprise that many hypertensives are on ACE and ARB, a smaller percentage on beta blocker, a very small percentage on case-sparing agents. And I put in diuretic and CCB for comparison. Here's looking at diabetes mellitus, another setting where you'd expect ACEs and ARBs to be used, and this is looking at a recent report, the 2007-2010 National Ambulatory Medical Care Survey, about 13,600 outpatient ambulatory visits, and I'll just look at the most recent year, 2010, they reported here about 32.2% were reported to be taking either an ACE or an ARB. So clearly in these settings, and you could look at heart failure, and you get the same thing. Last slide. This is looking at the ASK trial, and again shows what we know from other reports, that for those who have reduced renal function, there's much greater possibility of hyperkalemia with an ACE inhibitor. And I just put in here what is the prevalence of getting down to these low levels of renal function. Well, for 15 to 29, it's a pretty small percent of the general population. 30 to 59, it is, of course, a higher prevalence. So I'm going to stop at that point. There are two summary slides which you have in your packet.
Okay, thank you.
Pleasure.